good morning. So I'm gonna cover the precision medicine in CNS vascular disease. I have nothing to declare. And so my talk gonna cover the 5 sections. In the section 1, I'm gonna have a brief introduction about precision medicine and how it works in image. And we have a basic literature review of the genetic effect in stroke, and followed by some kind of case illustration. And we have a small summary about the future and the limitation, and get a key conclusion. So as the previous talk speaker already mentioned, precision medicine is more about to take into account the difference in people's gene, environment, and lifestyle. So the goal, the precision medicine is taking the right treatment to the right patient at the right time. So if you compare a guideline to precision medicine, the guideline more focused on solution in larger population. Whereas precision medicine focuses on understanding visual difference. So for guideline, we usually provide standardized treatment and tailored to genetic environment diet. It's the way precision medicine goes. So guideline focus on SOPs, common symptoms, and standardized tests, whereas the precision medicine will use more advanced tests such as genetic or radiologist examination. So the outcome usually guideline for looking for the best interest of the group is usually the outcome is optimal, suboptimal, whereas the precision medicine is more customized to individual need and with the target therapy. So the cost effective is in the guidelines more inexpensive, but precision medicine more tests means more money. And so let's have a general look about what it affects us in a daily common practice. So like anticoagulant warfarin, the activity will influence by the following 2 genes. The variation will increase or decrease the medication. So we have to monitor them based on the gene if they are available. And for antiplatelet treatment, as we all know, cloperidol have some kind of sensitivity, decrease metabolize if the patient have the CYP2C19 gene the variant. So we have increased the dose to achieve the ideal therapeutic effect. And for the somatostatin, it's MG-CoA reductase statin group. So if the patient have the following gene mutation, then you make the protein accumulate in muscle and induce toxicity. And of course, we all know that precision medicine is very common, popular in oncology. So if the breast cancer patient have the ER receptor positive, we can use Herceptin to do a more favorable outcome by target therapies. So let's talk how radiology play in the landscape of healthcare. So basically, we're doing 3 goals. Tasks like data generation, data integration, and clinical application, and it's all interactive. So from the beginning, we meet a patient, we'll collect their data into the systemic biology, digital, and the systemic neurophysiology and clinical information. Then we all get together, have the data. We have a big and deep data, and the image feed is in one of the subcategories. And then we will try to build up a system to do the 4P. And 4P, basically, we are very familiar with preventive and predictive and personalized in terms of treatment and participatory. So the right box kind of emphasize how radiology fits to the workflow. So radiology naturally fits in this workflow with low-cost integration and it's objective and quantitative. So in terms of neuroradiologies, we have different data sources from the 2 big domains like system biology and system neurophysiology and genomics. It's in addition to cytokine, intertone, and the lipidomic, metabolomic is filled into the biology part, and we radiologists, structural MRI, functional MRI, DTI, and PET MRI, etc. It's more on the image part. So we combine those 2 domains together, we can scale. So with a large scale, like a neural network, social media, and the intermediate grain scale, we have the structural MRI to detect the neuron structure. And in the microelectronic scale, we can see the signal transduction pathway. So let's get how usually we don't think drinking is bad for brain, but if the patient have the ALDH2 deficiency, which will cause accumulation for hydroxy, neuron accumulation, which will cause oxidation stress in the brain and in the cardiac. Also, for those patients have also known as Asian glow, they were more susceptible to the stroke. So in terms of, let's go to session 2. So in terms of talking about gene association in stroke, we can categorize into third group. The first group consists of single gene disorder that primarily cause stroke. And most common one in Taiwan is Calacio, and they have the NOTCH3 gene mutation, which causes protein accumulation in small vessel disease. In addition to stroke, they also have migraine, psychiatric manifestation, and the dementia. And they also have a counterpart, autosomal recessive form with the mutation in different gene. And in addition to stroke, they have associated clinical presentations such as premature baldness and spondylosis. And for hemorrhagic presentation, we have familial amyloid angiopathy, and they have the amyloid precursor protein gene defect, and they will cause more hemorrhage and clinical manifestation, including dementia and amyloid spell. And for the collagen 4 COL4A1 mutations, we also cause hemorrhagic presentation and have some kind of classic finding of superficial and deep hemorrhage in addition to small bleed. And for the second group, we have a genetic disorder that includes stroke as a manifestation. The hemorrhagic presentation will characterized by the most common one, erythema type 4 and Marfan syndrome. They have the gene mutation will cause weakness of the arterial wall, so subsequent cause the aneurysm, pseudo aneurysm, rupture, etc. And for the ischemia presentation, we have the Miller's and Fabry disease and the sickle cell disease and small muscle actin defect, etc. Then cause to the ischemic stroke via different genetic mutation. And we, as to mention that the sickle cell disease is most popular in sub-Saharan area and some part of America, and in Asia population, it's very little. So they can see how the gene play roles in different ethnic group. So the third group considered common genetic variation, polygenic, so they have a single mutation, but they will cause different kind of defect, including the mechanism, and eventually lead to stroke. So let's just focus on how they work to cause stroke. So they will cause vascular development and atherosclerosis and small vessel disease, like the coverage, the parasite coverage is not adequate, and thrombosis, the small vessel atherosclerosis, and some part will cause the SA node development mutation and cause the arrhythmia. So in clinical, before the imaging come to play, so in the neurologist use astroscope to predict the patient outcome after the stroke by using age, severity, and NIH score, and time delay from onset admission, etc., etc. So based on the score, the higher the score, the worse outcome you're gonna have after the stroke. And so how the image help in this area, though, by using integral polygenic score in stroke prognosis, based on different ethnic group like European, Asian, and African group, then we can identify those genes with greater risk to cause stroke and build on the model. So based on the model, and the European ethnic group was validated by clinical trials. So the patient with a higher integral polygenic score will more likely to have a worse outcome after the stroke. Just the idea same like an astroscope by clinical parameters. So how does image play? On the left, we can use a functional structure, functional connectivity, MRI, to identify those patients after stroke with motor deficit and the normal patient without clinical history. And on the right, we can use the functional connectivity to identify those patients with stroke with and without motor impairment by the functional connectivity. And the reason, the basic idea is, as you can see, the green spot means the affected site. We can see on the contralateral side if the patient have more prominent active area and a less hypoactive area, then the patient probably will have a better outcome by machine learning, etc., etc. So actually, the most common genetic defect called stroke is familial hypocholesterolemia. And based on the Western database, it's very popular. It's 1 in 250. And if you have this carrier, if you are a carrier, then you have 22 increased risk of coronary artery disease. And most people, they know they have high cholesterol, but they never receive gene test, and it's 80%, and only half of them use statin, and only 16 have a high-intensity statin prevention. That's the precision treatment for patient, for carrier, FB carrier. So we're going to the third section. We're going to use this diagram to illustrate different cases. So the idea is that on the right, we have 5 different data sets, including biomarker. So take a stroke, for example, we might have lipid profile as a biomarker, and in gene, we have ApoE, FH gene, and CADASIL-3 gene. And the clinical, we might use NIHSS score to estimate the ischemia burden. And the image, we are very familiar with that. We have perfusion, DWI, DTI, etc., and the grading. We might use a chest score to evaluate patient with the risk to have atrial fibrillation induced stroke. So on the left, based on the 5 different kind of data set, we can try to integrate to precision medicine on 3 P: prevention, prediction, and personalized. Take image in the green letters. For example, we use carotid ultrasound to detect the intimal thickness in FH patients, and we use we just talk about the functional MRIs to connectivity to identify patient might have the better outcomes after a stroke. And as a gene, how did it play? For patient have the CYP2C19 gene variant, we might to increase the therapeutic dose to achieve better expected effect. And for the patient have the gene-related low vitamin C deficiency, we might need to supply them with niacin or vitamin supplement to reduce their stroke risk. So let's use the first case, FH, for example. In biomarker, have elevated LDL, and the most common mutation actually is the LDLR receptor. But now we also have the target therapy for PCSK9 gene variant, and the symptom sign usually we also have a sensomas, and we use ultrasound to evaluate to screen patient for carotid intimal thickness, and for grading we use a multi-parametric clinical factor to evaluate the patient. And for the image, those patients more like to have microbleed in the cortical area. And the vessel tortuosity was not big different compared to diabetic hypertension risk patients. So the second most actually will turn out to be familial intracranial aneurysm. It consists of like 20% of the overall aneurysm. For the gene, we have the group 2 gene with hemorrhage as a presentation. Most common one will be PKD, polycystic kidney disease gene defect, and the clinical presentation, we know it's asymptomatic when we can use MRI, CT, ATSA to analyze the aneurysm. And the grading, we don't really have a grading for that, but we know it's a smoking and female have a higher risk to cause rupture and aneurysm. And several theories we propose, but we think interleukin-6, the inflammatory pathway, has something to do with the rupture of the aneurysm. So based on this kind of algorithm, we can find out if patient have familial aneurysm, probably embolization is a better way for approach, but because we don't know the patient will develop the second aneurysm somewhere else or somewhere. If the patient get operated, it becomes very more difficult for the second operation for kind of cancers, for the kind of scenario, and we also need to consult the patients if they already have sibling or parents have aneurysm, and the gene and screen may be indicated. And for the Oswald-Weber-Rondo syndrome, it's more common in the West with an incidence 5 to 8,000 per person. And we have different type of mutation like endocrine LK or SMART4. The symptom side, we base on the Curatio triad. So that if the patient have the recurrent nose bleeding and the red skin spot, and we use image to find, in addition to brain AVM, and we also find the pulmonary liver and spine AVM, then the patient is more likely to diagnose as Oswald-Weber-Rondo syndrome. And we don't have a biomarker for that. And currently, people try to use the anti-genosis medication to treat this kind of specific AVM. And for familial cavernous malformation, it's less common, like 200,000 per person, and more favorable in Hispanic population in Southwest the USA. We have 3 different type of mutation, and the symptom sign, in addition to brain findings like popcorn appearance, we also have the hyperkeratosis cutaneous and the capillary venous malformation of the skin. And we use the Zimbrowski classification with the classic popcorn appearance as type 2, class 2, and the class 1 is the recent bleeding, and class 4 with those small microbleeding only, microcavernoma only detectable in SWI. And for the biomarker, we don't have biomarker for that. So as we can see, so in terms of the risk analysis, we can kind of expect based on deep learning, etc. We can based on location, cavernoma size, and number to particular patient outcome. CADASIL, it's cerebral autosomal dominant enteropathy with subcortical infarct and local enceropathy. It's a NOT3 chromosome 3 mutation and with a poor inconvenience in muscle. The migraine and the clinical symptom is associated with migraine and the dementia. Most impairment is executive function. And the classical finding will be like anterior temporal lobe and with subcortical and anterior temporal lobe and external capsule. And in addition to subcortical white matters. And so we have different grading by white matter disease and the biomarker. They don't have zero biomarker, but we can detect some kind of spatial finding during the skin biopsy. And the reason why I put the 100 here is because in Taiwan, we have very common and popular, like so 100 in one, we have the carrier of the disease. And for CADASIL, it's the autosomal counterpart. The image finding it's very distinguishable, but the image symptomatically they have the alopecia and disc herniation, and the instance is relatively rare. And for this is even rare, like overall we have 50 cases worldwide, and it's a kind of genes, colony stimulation factor 1 receptor defect and have white matter changes. And in addition to those, we have the classification over the involved area, and the clinical symptom presentation also have the kind of dementia presentation. And for the Millers, we had the mitochondria encephalopathy with lactic acidosis throughout the episode. So it's 4,000 in one. And we have a mutation here. And the key finding will be like in the affect and non-affect area, they all demonstrate elevate the lactate peak. And the concentration of lactate peak in affected area, it's correlated to the patient prognosis. So based on the kind of imaging and serum finding and the MRS finding, we can decide what the best treatment for the patient in the follow-up. Hereditary cerebral amyloid angiopathy, it's 1 in every 5,000, and I'm sorry for the typing. The most common one will be like CCA1 type 2 and followed by CCA2, the Iceland subtype, and CCA type 3, British and Dutch type. And the symptom signs, cognitive decline, recurrence headache, and lobar cortical microbleed, etc. And we use Boston criteria to evaluate hemorrhage severity and white matter change. And we don't have a mark for that. The hallmark, it's like an integrate hemorrhage in adjacent to the microbleed. And So for the last, we're gonna have the cerebral facial arterial metabolic syndrome. That's my favorite because it classic beautifully illustrates how the gene, one single gene affect the whole three layer like exoden, mesoden, and endoden. So the take somaton 2 involvement, for example, we have avian in diencephalon, thalamus, and the apical chiasma and the maxillary. So for those patients, usually there you can find among them the VEGF elevation, and so far we still use Spessler Martin gray to evaluate the patient, and the symptom side we can see the pharmacococcal ocular involvement, etc. So let's go to the section 4. Stroke make study. We have the 10K Chinese with stroke, and we studied the gene. We turn out we have 135 million variant, but only 42% are correlated with Western findings in the Western society. And those patients, if you use that to estimate a stroke model prediction, only can explain 40%. So most of them contribute to lots of vessel atherosclerosis and stroke. And for gene-wide association study, they identified the 18 stroke-related trait and discovered 15 genetic association. And for the specific gene, the reproducible finding are PCSK9 and the ApoB and the GCKR. And the behavioral trail, like we saw the Asian growth syndrome, ALDH2 gene, and heavy drinking kind of behavior will be bad for those patients with the kind of genetic defect, and the image finding is still ongoing. But we didn't find that patient, why Asian population have higher intracranial stenosis contrast to Western population. They more likely to have intracranial stenosis. So far in this study, we didn't find gene related to that. So for pattern recognition data, I'm sorry I cannot be any more useful in this talk, but this is from the neurology, like when we encounter adult white matter hypertensities, we can categorize into acquired disease if those present white matter changes are symmetric distribution, ganglion enhanced, and rapid growing changing. And for the genetic disease, if the vascular MRI is demonstrate microbleed lacuna infarction and have specific brainstem external capsule and deep gray vital involvement, and we probably is not true. But if have the cavitary finding in addition white matter distribution, we might see this vanished white matter syndrome. And for the others, you might do some kind of metabolic screening or gene test to identify those. So the mutation gene study, it's fancy, it's complicated, but they also have limitation because the interpret is very complex. So you need really have very rigorous statistical analysis to get to target the really useful one. And currently, more biobank is separated, so the efficacy of the big teamwork is have some space to improve, and potential false positive, as I expect, it's an association study, it's not subsequent study, so lack of future functional evidence to identify the patient. So we definitely the longer observation and follow-up to see if these patients at the genetic risk are really useful in the daily practice. So that's the next slide. The genetic single gene, in stroke, we can categorize 3 groups: single gene, polygene, or the protein that cause different mechanism and finally cause stroke. And the biobank, it's good, yes, but we definitely need a longer longitudinal data to identify, to validate those genetic risk. For the image, symmetrical confirmed pattern suggests genetic disorder, and functional MRI predict functional outcome. Pattern recognition, it's our favorite, but currently it's probably out of date. We definitely need gene to help us. And for the precision, precision is more about prediction, prevention, participatory, etc. For personalized medicine and genetic environment have something to play. Genetic can explain only 40% of the models, so we need the lab scene to improve, and those findings will help the industrial to develop, make to a better ecosystem. So AI-aided decision support system will be the future when it comes to the concept of diagnosis. So we have to collaborate with the gene and other data. Okay, so that's end of my talk. Thank you.
Okay, thank you, Professor Lin, for these excellent lectures to tell us about how to manage and evaluate different aspects of different kinds of CNS vascular regions, including genetic test, imaging monitoring, and also the biomarkers. Because of the limit of time, so if you have any questions, you might visit Professor Lin after these sections. And also, I would like to close this section, and on behalf of the committee, the organization committee, I would like to present Professor Lin the certificate of appreciation.